What can we do about it? The respiratory muscle pump, and then we mostly talk about the diaphragm, is really a fantastic muscle. It is, and you've seen the picture before, this dome-shaped muscle positioned between the thoracic cage and the abdomen. And it's really amazing. If you look with ultrasound to the diaphragm, it's only 2 millimeters in thickness. And it fulfills a fantastic task. It drives our ventilation, right? Upon contraction, you've seen that, it generates a negative pleural pressure, and air flows from the atmosphere into the alveoli. And the activity of the diaphragm is very well regulated. As Diederik explained yesterday, a small decrease in pH has a tremendous effect on your respiratory drive. It will immediately increase the output, mechanical output of the diaphragm. But it's important to remember that the diaphragm is not the only muscle active in respiration. It's the same thing if you talk about cardiac function and you only look at the left ventricle. I mean, there's a right ventricle as well. And if you look at the respiratory muscle pump, there's the diaphragm, but there's a lot of other muscles that are active during respiration. It's the accessory inspiratory muscle, the intercostals, the scalene, the sternocleidomastoid muscle. But during expiration, in particular when respiratory demands increase, the expiratory muscles play a very important role. And I don't have time to address that too much now, but it is a very important topic. So your maximum inspiratory pressure, just to give you a little bit of an idea, if you do a maximum inspiratory occlusion, you generate a pressure of around 100 centimeters of water, somewhere between 80 and 120. Well, how much pressure do we need for tidal breathing? How much pressure does your diaphragm generate right now?
2.
Yeah, 2, 3, 4, 5. I mean, if David explained us yesterday, compliance of the respiratory system is 100. So if you generate a pressure of 5 centimeters of water, you get a tidal volume of 500 ml. So there's a huge reserve capacity there. And I'm very sure that everybody in this room is aware of the fact that patients in the ICU develop weakness of the respiratory muscles. There's a lot of studies out there now, and this is just an example. Very nice study from Samir Jabet in France, and he demonstrated that after only 3 to 4 days of controlled mechanical ventilation, pressure generating capacity of the diaphragm was reduced by 25%. So can you imagine? After a few days of mechanical ventilation, you lose a lot of pressure generating capacity of the respiratory muscles. So it goes very fast. And it happens in a lot of patients. This is very nice data by Alexander de Moule, published last year. So a rather small group, but it gives you an idea. 43 patients that were ventilated for at least 5 days, but he measured pressure generating capacity of the diaphragm from day 1 on. And there's an interesting thing, and we're going to discuss that later. But on the day of admission, 53% of the patients already fulfilled criteria for diaphragm weakness. And of the patients that did not fulfill criteria of diaphragm weakness on the first day, 26% developed somewhere during ICU stay diaphragm weakness. So weakness of the respiratory muscles in patients that are on the ventilator for at least 5 days is very common. In total, it's about 80%. It could be a little bit less, a little bit more, but it is an important problem in our patients, and everybody will recognize that, I guess. Oh, yes.
Sorry.
No problem.
Yeah. Why would the patient have on admission only a diaphragm weakness?
Okay, I'm going to ask you later on.
Because it's my way of measuring it maybe incorrectly.
I don't think so, because what they did right here, and I skipped this picture, what they did is a very objective way of measuring pressure generating capacity of the diaphragm. As shown right here, What they do is a magnetic stimulation of the phrenic nerve. So they use 2 coils, there's an activation of the phrenic nerve, and they measure how much pressure the diaphragm generates. So this is not affected by patient effort. It's not affected by sedation. It's a very objective way of measuring, well, function of the diaphragm. And I'm coming back to your question, and if I forget, you ask me at the end, but I'm coming back to this. You had another question?
Well, can you show the next slide, please?
Sure.
So maybe you will discuss this later. So the improving this function profile is interesting because
Exactly, and it has.
That's the answer to her questioning.
Exactly.
Okay, and then I was for it.
Well, I can already give you a hint. I mean,
because this is very clinical and practical. So when we want patient to give a rest.
okay. I can already give you a clue. I mean, some patients get into the ICU with more or less heart failure. And how do we call that? It's a kind of septic cardiomyopathy, right? We think that all these cytokines or whatever at least gives a temporary decrease in cardiac function. And then the inflammatory phase is over and cardiac function improves. And that's the idea as well here. That these patients, because they are having a pneumonia or having a sepsis, there's an immediate reduction in function of the diaphragm. So this is a kind of septic respiratory muscle myopathy. That's actually the case right here. I don't want to spend too much time. I mean, everybody who's working in the ICU knows that development of respiratory muscle weakness is associated with poor outcome. And the most obvious one is that the patients who have become really weak spend more time weaning the ventilator. And that's exactly what the group by Alexander de Moule has demonstrated. It doesn't matter too much if you have peripheral muscle weakness, but if you have respiratory muscle weakness, you spend much more time weaning the ventilator. And another important message, but it's good for discussion later on, that there is not such a good correlation between peripheral muscle weakness and respiratory muscle weakness. So you can't say if the patient is strong in his peripheral muscles, that respiratory muscle weakness is unlikely. And that's what this study very nicely demonstrated. But there are some technical issues. And the other thing which is important in outcome is that if patients have weakness of the respiratory muscles after extubation, it is an important risk factor for readmission to the hospital or the ICU in the first 6 weeks thereafter. So if you develop respiratory muscle weakness, it's not like if you get out of the ICU, it's not important anymore. These patients still have a higher risk of all kinds of complications, including readmission to the ICU and readmission to the hospital if you're already home. So right here, the pathogenesis of respiratory muscle weakness. So this is, well, let's go back a little bit to the physiology, and we have to start up our phones again. So which statement is or are true? The first one is that histological evidence demonstrates that disuse, so controlled mechanical ventilation, largely explains diaphragm dysfunction in ICU patients. And the second one is that oxidative stress plays an important role in the development of diaphragm weakness. So which of these two statements is true or not true at all? Give you a few minutes. Should I go to the next slide, Estelle? Both are true. Okay, I'm going to show you this. Both are false. And I think you've all seen this picture. You've seen it a million times. But what we often forget is that these are brain dead patients. This is not your typical ICU patient, I hope, right? These were patients that are brain dead. And then indeed, and everybody tells it in the conference, and I did it myself as well, because we were so happy with this paper, it showed that after only a few hours of controlled mechanical ventilation, there was atrophy of the diaphragm. But again, this is a very specific population. And right here, in the Netherlands, we're happy enough. We now have a kind of large study going on where we obtain biopsies of the diaphragm of real ICU patients. So patients that are in the ICU on the ventilator for at least 2 days, and biopsies are obtained during laparotomy or thoracotomy, for whatever reason. And I think that gives a little bit more insight of what's really going on. So first, if you indeed take biopsies of the diaphragm, there is a reduction in cross-sectional area of the fibers. So yes, these fibers become smaller. Not very surprising. As I'll show you in a few minutes, it's consistent with ultrasound data. But if you look in more detail, and I'm not going to discuss it too much, but if you look in more detail, there's a high level of inflammation in the diaphragm. There's a high number of macrophages in the diaphragm of the critically ill patients compared to control patients. And controls is just patients coming in for elective surgery. There's more neutrophils in the diaphragm. There's more cytokines in the diaphragm. If you look at the ultrastructural, so this is electron microscopy. If you look, so you will recognize this as a normal diaphragm. And right here, there's a complete disarray. I mean, you don't have to be a pathologist to see that this is bad, right? So there's a complete change in structure of the diaphragm. I'm not going to bother you in detail with these kind of things, but we have looked in depth to mitochondrial function, electron microscopy, functional things, and they are exactly fine. They're completely fine. Nothing wrong with the mitochondria. We have learned earlier from these brain-dead patients, there's all kind of problems with the mitochondria. We have learned from all very important animal studies that things are wrong with the mitochondria in prolonged mechanical ventilation. But if you look at the real ICU patients, it looks completely fine. If you look at oxidative, nitrosative stress, no problem at all. So I think this very nicely demonstrates that there is a discrepancy between the things you find in animal research and in our real ICU patients. And also the whole hypothesis that was generated was largely based on brain-dead patients. Again, completely different group of patients than our normal ICU patient, right? And an important conclusion was, when we looked at all this histology, is that this was not consistent with disuse. I know, we know how a muscle looks like when you don't use it for a couple of days. And what we found here is not consistent with disuse atrophy. And, well, it's the same thing as Alain said. When I was rounding in my ICU, and we look at a lot of patients, at least in the Dutch ICUs, we go to a partially supported mode pretty soon, and you see a lot of patients actually having a high breathing effort on the ventilator. So idea now is a little bit more, does the high breathing effort play a role, instead of what we thought, disuse atrophy. And this is rather, well, perhaps provocative, but I'm going to tell you my opinion, and it's open for discussion later on, but you have to think about it. So this is a typical patient in the ICU, PF ratio 135, pH 746, and what we would like is a 6 ml per kilogram, tidal volume of 420. As you can see right here, this patient has on 12 of PEEP, 5 of pressure support, a tidal volume of 700 ml. So this patient has a high respiratory drive, and patients like this actually stimulated us to do this study. So this is a group of patients that are recovering from AIDS. pH is plus minus normal, PF ratio, if I remember well, around 200, and this is the tidal volume at pressure support of 12. So 12 of pressure support, tidal volume, almost 10 ml per kilogram. So what do you want to do? Thank you. That was what I was looking for. So tidal volume goes down. Pretty happy, right? Right here, pressure support is 6. So we think that we're doing a good job. And we might do that from the perspective of the lung. We're getting closer to lung protective ventilation, right? But don't forget the diaphragm. Because right here, to start out, this is the electrical activity of the diaphragm, which tells you something about the respiratory drive. You can see, as expected, if you reduce your level of pressure support, the diaphragm is going to work harder. Electrical activity goes up. If you look at the transpulmonary pressure, therefore, it didn't really change. So you think that you're doing something that's like lung protective, a little bit reduction in tidal volume, but transpulmonary pressure, as was explained yesterday, which is the important pressure, doesn't change. But this is what I want to show you. If you look at the work of breathing, and a normal work of breathing is 0.4 joule per liter, right here. So this group of patients already had a work of breathing around 0.8 joule per liter at 12 of pressure support. And what almost everybody in this room would do is, as you said, reduce your level of inspiratory assist, but what will happen is that there is a tremendous increase in the work of breathing by the diaphragm to 1.2 joules per liter. So we're doing something good for the lung, probably, but probably not for the diaphragm. And this will go on for days, 24/7. So that's where the hypothesis comes from, that perhaps it's not disuse that's the problem, or the only problem, but there is a problem with too high respiratory drive, which is acting for a long time.
It's like when you overtrain an athlete.
Exactly.
And on the race, he's not going to perform because he has overtrained, so he's strained.
Exactly. And then you can develop injury, you might develop, but you know, I am a bit provocative here, and I'm going to, the evidence is not, it's not final, right? But this is something that we have to look. If you go to your ICU, everybody will recognize this patient on low level of support or on CPAP having a tremendous respiratory drive, and if they more or less accept or whatever, this mechanism might play a role. This is a great study by Ewan Gallagher, looking at thickness of the diaphragm in ventilated ICU patients and measured thickness of the diaphragm for 7 or 8 days in a row. And he found that in, say, 45% of the patients, thickness of the diaphragm did not decrease or increase. In 45% of the patients, the thickness of the diaphragm decreased by more than 10% in the first 3 to 4 days of mechanical ventilation. There is a group of patients that develop atrophy. But the interesting thing is that he also finds a group of patients that have an increase in thickness of the diaphragm. And you might think, that's a good idea. This is training, this is hypertrophy. But that's actually not the case. There's an increase in thickness, but still dysfunction. So it is likely that this is actually injury in the diaphragm. So that's consistent with our idea right here. And very recently, a couple of weeks ago, he published this paper, and he looked at the change in thickness of the diaphragm and the likelihoods. It's pretty complicated what it is from a statistical point of view, but the message was, if you have a decrease in thickness of the diaphragm, you have a higher risk of being bound to the ventilator or a lower risk of being weaned. Right? That's something we more or less predict. If your diaphragm gets thinner, it's more likely that you spend more time on the ventilator. But the same thing is true if the diaphragms get thicker. If your diaphragm gets thicker, it's not hypertrophy, it's a good idea. You also spend more time weaning the ventilator. So in the interest of time, I skipped this, and that's why, and it was only published today in the Blue Journal, so I'm really up to date with my slides, I guess, right? So that's why we have now the concept of trying to get to diaphragm protective ventilation. We have lung protective ventilation, and now let's start to think about the concept of diaphragm protective ventilation. And I have to be honest, I don't know what it is, but it is a good idea, I guess. No, but I mean, what we try to explain in this editorial is the diaphragm protective ventilation is that you should aim for a breathing effort which is plus minus normal. If you can measure breathing effort and you try in all your patients, if you want to be on a partially supported mode, aim for a pressure generated by the diaphragm around 4 or 5 centimeters of water. So, on one hand, you try to prevent disuse, which results in atrophy, but on the other hand, you try to prevent heavy loading for 24/7. So this is something. Let's try to be in this range where, well, there's a physiological loading of the diaphragm, physiological work of breathing or effort or whatever. Sounds reasonable, right? But it's not that easy, because I guess most of you won't measure the effort by the respiratory muscles. Just the normal ventilator doesn't give you a clue. So we have to find a way to monitor activity of the diaphragm. And I think there's several techniques available, and I'll briefly discuss 3 of those. It's the esophageal pressure, EMG, and the ultrasound. So esophageal pressure. We have discussed the techniques, the limitations, etc. yesterday, and for those who are interested, I can really recommend you to read these 2 review papers that really discuss it into detail.
Oh, no, go back.
No, sorry, too late. Go back. Yes. Okay, it's on the list, yeah. You really, I mean, if you start reading after this course, read these 2 first, I guess. Or perhaps our editorial, but I'm a bit biased. Sorry. This is pretty simple. I mean, you can make the measurement of esophageal pressure very complicated. But if you're just interested in looking at diaphragm effort, it's simple. I mean, the esophageal balloon, it's like 30 euros. It's not expensive. You insert it, you do your validation. You don't have to buy a very expensive pressure transducer. Just for clinical purposes, we use the one we use for arterial blood pressure measurement as well. I mean, it might be 0.5 centimeters off, I don't care. Because now you don't have a clue. And now you at least have an idea. I mean, perhaps you don't accept it for research, but for clinical purpose, it's good enough. So if you look right here, so this is esophageal pressure. So you see the patient taking a breath, and it's a change in 7 millimeters of mercury, so 9.5 centimeters of water. So I have a rough estimation of what my patient is actually doing. And I get the data in a minute. And if this is too much, I can try to increase pressure support or whatever support a little bit and see how it affects the pressure. And this might not be a problem, 9 centimeters of water, but if you go on the measure, you will find in some patients pressure swings of 20 centimeters of water. And you don't have to be a physiologist to understand that this has an impact on the patient. Okay, my second question here is, I just did measure changes in esophageal pressure during inspiration. But what does it actually tell you? Is this the effort of the diaphragm during inspiration? Is this the effort of all the inspiratory muscle? Is it affected by relaxation of the expiratory muscles? Or has it mostly to do with changes in compliance of the chest wall? Can we go to the next slide, Estelle? Oh, so you need more time to read? Okay, very well. Yes, I think this is, I think this is more or less the right answer, right? It is the activity of all the inspiratory muscles. Right. During inspiration, even if you don't use your diaphragm, imagine if your diaphragm is completely relaxed, but you do an inspiration with your intercostal muscles, scalene muscles, or whatever, you will generate a negative pressure in the thoracic cage, which is reflected by a change in esophageal pressure. So keep in mind, a change in esophageal pressure reflects the activity of all the inspiratory muscles. And if you're really interested in the activity of the diaphragm, you have to measure the transdiaphragmatic pressure. So you need both an esophageal and a gastric balloon, and the pressure generated by the diaphragm is the difference in these two pressures. So you can imagine if during inspiration the diaphragm doesn't work at all because of bilateral phrenic nerve injury, for instance, the diaphragm will just, well, move up and down without any activity, so your transdiaphragmatic pressure is 0, right? So you always have to be careful if you measure just the esophageal pressure. Well, that's nicely shown here as well. I mean, this is your esophageal pressure, gastric pressure. As you can see, during inspiration in this patient, there's a drop in esophageal pressure and an increase in gastric pressure. But I think mostly for clinical purposes, you're completely fine with just the esophageal balloon. So the esophageal balloon, I think it's not too complicated, at least not for the respiratory effort. It requires some expertise, but if you read those two papers, you're doing a good job, I guess. And then, because that's a difficult question here, what is lung protective? I mean, what's your reference? What's your target? And I think for now, it's 3 to 12 centimeters of water. But I'll come back to that later, if you agree or not. Second, diaphragm EMG. And there's actually two techniques. You can use the surface EMG or the esophageal catheter. Surface EMG, it's very nice. I mean, you can actually track activity of any muscle you want. So if you want to track activity of the scalene, the intercostals, the diaphragm, I mean, it works out for research purposes. But for clinical purposes, it's a pain in the ass, right? Because the patient is moving all the time. The nurses hate it because these stickers, they detach. I mean, I don't think it's going to work for clinical purposes. But if you want to look at patient-ventilator interaction, if you want to look at if there's activity of the muscles, it works out. But I think for clinical purposes, it doesn't really work out. So most of you are probably familiar, and otherwise we'll discuss it in a workshop in the afternoon or tomorrow, with the EDI or the NAVA catheter, which is a dedicated nasogastric tube which has 9 electrodes positioned at the level of the diaphragm. And it was designed to be used in the NAVA mode. But I think it is basically a fantastic tool for monitoring diaphragm activity, even if you're not using the NAVA mode at all. And I have to be careful because people from Mackay are in the room. But it is, even if you're not using NAVA, as a monitoring tool, it works out very well. So right here, in this example, I have a patient in the NAVA mode, but it could be pressure support as well. And this is a support of 0.6. Details will follow later. And right here, a support of 4. You can see that there is a change in the amplitude of the electrical activity of the diaphragm. So it's right here, with low levels of support, the amplitude is around 11 microvolts, and with higher levels of support, the amplitude decreases. So it is indeed very nicely shown that the amplitude of this activity reflects effort of the diaphragm. No, the movies are even working, but I guess you get the point. Now the important thing is, because it doesn't tell us much if electrical activity is 12, From a physiological perspective, I'm interested in pressure, right? 12 microvolts or 20 microvolts, it doesn't tell me too much. And this is a great study by Giacomo Bellani that has actually shown that there is a linear relationship between the electrical activity and the pressure generated by the diaphragm. So one could say, well, at 8 microvolts, the pressure generated by the diaphragm is 2 centimeters of water. But there is a problem, because this is only one patient, and every patient has his own, I'll say, steepness of this curve. So if you say, well, EDI, if you call me at night, I hope you don't, but if you call me at night and say electrical activity is 8, is that fine? I don't know, because your pressure could be 2, which could be 8, and could be even higher. So what we need is, in one way or another, convert electrical activity into pressure. And that's what we're going to do this afternoon or tomorrow in the workshop. I can show you, and there might be a way to do so. But we don't have to make it so complicated. I think this is a fantastic example. Look at this. This is a patient, and you understand all now, with COPD. There's an expiratory flow limitation, 30% of oxygen, 8 of PEEP, and 8 of pressure support. And look right here. If you look at the electrical activity of the diaphragm, there is no activity. The diaphragm is completely inactive. So 1 minute later, I'm going to reduce the level of pressure support to 4, as shown here, and immediately there is activity of the diaphragm. So in this previous example, and I think most of us would feel comfortable with 8 of pressure support. You would say, well, I mean, this is a reasonable support, the diaphragm is active, right? But obviously, and really, if you didn't have this EDI catheter or perhaps an esophageal balloon, you would not be able to detect this. Because, again, if I go back to the previous one, you can't tell from the flow curves, right? Yes, thank you for the question.
Sorry, and you still have
yeah, a drop in pressure here?
no,
Oh.
you have no trigger from the diaphragm?
No, this is pressure support.
Yes.
So this is pressure support.
Pressure support.
So it looks
But you are triggering,
Yes,
but not by the diaphragm.
right.
yeah.
So why is this patient triggering? I mean, because he is triggering the ventilator. Why is this patient triggering?
That's what I was saying.
Exactly. Thank you for the question. So now I'm asking you, why? Think about it. I mean, this is physiology.
Auto triggering from the ventilator problem.
No, this is not auto-triggering.
Are we inspiratory muscles?
Yeah, that's one hypothesis.
Ah, yes.
Actually, not the case here. This is why you're here. This is why mechanical ventilation is fantastic. I mean, this is not like my cytokines are 10,000 and in this patient 5,000. No, this is physiology. In the end, we have to understand. Okay, imagine a patient with COPD. How is a patient with COPD breathing during expiration?
I won't say it because I can say
Accessory muscle. No. A patient with COPD is breathing like this during expiration, using expiratory muscles, and then he releases the expiratory muscles. Releasing the expiratory muscles causes a drop in airway pressure, and that triggers the ventilator. So this is actually fantastic. We never published it, and we should, but didn't have the time. But this is fantastic. He is triggering the ventilator with its expiratory, by releasing his expiratory muscles. So even before the diaphragm becomes active, so and why doesn't he do that when they reduce the level of pressure support? As Alain said, it reduces the level of hyperinflation, so he's not using the expiratory muscles that much anymore, he's using the diaphragm. Yes or no?
It's one of the good indication to have measurements of the gastric pressure.
Exactly.
But I don't know if you think the same way, but it's not so easy. So esophageal pressure now, okay, if you try to measure the esophageal pressure in 3 patients, you will understand it is not very complicated. For gastric pressure, sometimes.
Oh yeah, I could talk for hours. I left it out here. I can talk for hours about, and I completely agree, and I hope we will discuss it a little bit more. My time is up?
Don't 4 hours, you are still 5 more minutes.
1 more minute?
5.
5, okay. This is fantastic, and this is the reason why you're here, and this is why mechanical ventilation is fantastic. You think about it, you call him at night and ask what the problem is. No, but this is why physiology and why mechanical ventilation is fantastic. Okay.
One way is to put the other hand on the abdomen.
Yeah, right. Yeah.
Just, you can sense the expiratory effort.
Yeah.
And then, the releasing of the effort corresponds to the beginning of the...
Okay, very quick, ultrasound. If you think, well, I don't want to use the EDI catheter, I don't want to use the balloon, I think most of you will have ultrasound, right? And you can use ultrasound to assess diaphragm function as well. Right here, probe is in the subcostal position. This is the liver. This white brim here is the diaphragm. I ask the patient, inspiration. The diaphragm, of course, moves to the probe. Deep inspiration. It moves a little bit more towards the probe. And you can ask our fellows and residents, you can learn this in a few hours. I mean, the subcostal view, looking at diaphragm, is easy. And if you even use the M mode, you can do a quantification of how much the position of the diaphragm changes, how much it contracts. There are reference values, during tidal breathing, 1.5 or 2 centimeters. But keep this in mind, you can only do this when the patient is disconnected from the ventilator. Because in a patient on volume control, on full muscle relaxants, the diaphragm will move downward as well. So if you want to estimate diaphragm function by the subcostal view, you have to disconnect the patient from the ventilator. Otherwise you get totally confused. If you want to measure thickness of the diaphragm, changes in thickness during inspiration, you can do it while the patient is on the ventilator, because a passive movement of the diaphragm will not result in thickening. Only if, well, same thing here, if you have an active contraction of your biceps, it will increase in thickness. And that's the same thing for the diaphragm. Okay, I'm going to skip this because, yes, this is and then I have 2 more minutes. And we come to the end of the talk, and I could say, and I hear you in the back of the room thinking, well, nice talk, but you didn't show any evidence that diaphragm monitoring improves outcome. I didn't even show any study that actually guides me to reference a certain value for activity. So what's your opinion? What do you think? I'm not going to monitor at all, nice talk, but let's go for coffee and skip this item. Or do you say, well, there's a reasonable physiological rationale, we should start doing it, or give me more arguments to convince me? I'm afraid you have to come back in 10 years. And I see it's important but too expensive. I guess you can predict what my answer would be, right? But I think it's important. Thank you very much. I think we have at least created a good atmosphere here, right?
It's a key of success.
Well, of course, and that's important. We need evidence that monitoring improves outcome, but it is challenging. I mean, this nice editorial has demonstrated there is no evidence out there that an arterial catheter for blood pressure measurements improves outcome. And you use it in most of your patients, right? Because it feels for us there's a good physiological rationale to have a minute-by-minute information on blood pressure. But then you could say, well, at least I know a reference value. Well, I'm not sure. You still can get into the New England Journal of Medicine by studying reference values for arterial blood pressure. So if you want to wait for the diaphragm, I think we have to wait for a long time. But again, think about the physiological rationale. And I think I should stop here. Thank you.